Anaga Kalada on distributional cost effectiveness analysis methods. Are you able to move to the next slide, please, Natalie? So for those of you who don't know me, I am Lisa Higgins. I'm based at Monash University and I am co-chair of the ACTA HEAT group. I'd like to begin by acknowledging the traditional custodians of the lands on which we all live, work and meet today, which for me is the Wurundjeri people of the Kulin Nation, and pay respects to their elders past, present and emerging. And we extend that respect to any Aboriginal and Torres Strait Islander peoples here today. So just some housekeeping before we begin. So please ensure that your microphone is on mute and then raise your hand to speak in the Q&A session. Anaga, would you like people to wait for questions at the end, or are you happy for people to ask questions during the presentation? What is your preference?
I don't mind either way,
Okay.
So they're welcome to.
Okay, so if you have a burning question, but otherwise please put questions in the chat, which we can answer as we go along, or we can look at and I can ask Anaga when the presentation is finished. We will have a recording of the webinar that will be available to watch on both the ACTA website and the ACTA YouTube channel. And when we finish the webinar, as always, we will have a brief post-webinar survey. We would really appreciate that being completed. So our speaker today is Anaga Kalada, who's a health economist and NHMRC fellowship holder at the Leader Centre for Health Policy, Economics and Data at the University of Sydney. Her work focuses on progressing and applying methods to incorporate equity concerns into economic evaluation in Australian health policy settings. She serves as a chief investigator on an NHMR-funded initiative developing childhood obesity models for priority populations and on an MRFF-funded trial of a social prescribing intervention for families of a child with a neurodisability. She's also involved in a project that integrates ethics and equity into HTAs of genomic newborn screening. Anaga is going to talk about distributional cost effectiveness analysis methods, illustrating their application with examples from both the UK and Australia, and look at exploring opportunities and challenges of implementing DCEA within the Australian policy landscape and highlighting alternative equity informative approaches. So I think we'll hand over now to Anaga to share your screen, and I'm really looking forward to this.
Thank you so much, and thank you so much for the introduction and the opportunity to speak to you today. I'm just going to get my tech working. Just need to make sure this is working.
Yep.
All right. Hi everyone. You can hear me and you can see my screen.
Yes, it's all perfect. Thanks, Anaga.
Okay, great. So my name's Anaga, as Lisa just mentioned. I work at the Leader Centre for Health Policy, Economics and Data. You've actually introduced the talk quite well, so maybe I'll just get straight into it. All right, so I'd like to also acknowledge the traditional custodians of the lands on which we're coming from today. I'm coming to you from the lands of the Darug and Guringai people, and pay my respects to elders past, present and emerging. So I thought I'd start with a little bit of a background. Again, a lot of this has already been mentioned, so I'll be quick. But in terms of this topic, my interests have started essentially during my PhD, which was around applying or developing an economic model for childhood obesity that could be used to conduct cost effectiveness and equity impact analysis of childhood obesity prevention strategies. And so the last study I did as part of this was a demonstration of a DCEA using that model. And then that got me interested really in how those sorts of results and these types of methods could be applied in a practical sense in Australian policy. And so I wrote up this proposal, which eventually got through around ways, or I guess, yeah, a methodology to embed and apply equity informative economic evaluation methods to Australian policy. And I should say there that this project isn't particularly focused or isn't specifically focused on DCEA, although it's a very large part of it. But I am interested at this point in the range of methods that are available and what might be more appropriate for what context. And as Lisa mentioned, I'm involved in a few other applied projects that are related to equity, and so I'm constantly thinking about how those methods can apply in that sort of technical sense in those contexts. So I'm going to start with an introduction to these methods. Some of you may already be aware of this. But distributional cost effectiveness analysis was developed by Richard Cookson's team at the University of York in United Kingdom, and it's defined as a group of techniques which evaluate the impact of an intervention on the distribution of costs and benefits of an equity relevant variable. So the team at the University of York have this beautiful animation on their website that I think quite nicely presents the gaps that or the concerns that DCEA is trying to resolve. So I just thought I'd play that. I've tried to share my sound, so hopefully that will work.
Public health policies. Generally, they're designed to benefit the average citizen, but almost no one's average. People get left behind. Health is at stake, so we need to know when this is happening, but we so often miss it. One problem is how we judge whether a policy is effective. We traditionally measure the average benefits across the whole of society. That means we don't see how outcomes vary by social group. Averages don't show us this gap. If we did measure the gaps, we could judge whether a policy is fair. That's when things get complicated. Here, all groups get the same benefit. But wouldn't it be fairer if the worst off gained the most benefit? It would certainly be less fair if the worst off gained the least. How can we account for these gaps when assessing a policy? Let's draw an equity impact plane. On this axis, we can still measure average effectiveness. But on this axis, we can measure equity. Do the gaps widen, stay the same, or get smaller? Sometimes policies are assumed to be effective for everyone. But really, they widen the gaps between groups. Or policies close those gaps, but aren't cost-effective overall. We really don't want policies here, with no overall benefit and wider gaps. What we do want are policies here. Overall benefits, and the gaps are smaller too.
Right, so in summary, standard cost effectiveness analysis focuses on average costs and benefits, but this could miss out on important information around who those costs and effects accrue to. Sorry. All right, so I don't need to explain the cost effectiveness plane to this audience, but just as a comparison of standard CEA to DCEA, a cost effectiveness analysis will allow you to present your results on this plane, which keeps incremental costs and incremental effects as separate axes, and that allows you to get your four quadrants of win-win, lose-lose, lose-win, and win-lose scenarios. And then sometimes we apply a cost effectiveness threshold, which would then allow you to work out what is cost effective or not, based on which side of the threshold your intervention lies. In a distributional cost effectiveness analysis, that cost effectiveness plane is now collapsed onto one axis, where that threshold is in the middle line. And so anything above the x-axis is considered cost effective, and anything below is cost ineffective. And then your anything to the right of the graph is improving equity, and anything to the left harms equity. So now we're looking at, rather than the trade-offs between costs and effects, we're looking at the trade-offs between cost effectiveness and equity impact. So DCEA should allow you to place your intervention on this sort of plane. Okay, so here I'm going to briefly discuss the potential components of a distributional cost effectiveness analysis, while acknowledging that this is not going to be a completely comprehensive run through. And the other thing to note is that not all these components are mandatory for every DCEA that's conducted. So as I said earlier, it's described as a toolbox of methods that you can pick from when you're designing a DCEA. So the first set of the components involve simulating distributions. So you start with your baseline distribution of health. So here, health can be anything, often QALYs, and your distribution can be across any sort of social variable. Here I've got, as an example, socioeconomic position. You then go on to model your final distribution of health after your decision or after the interventions being implemented. And so there's lots of things that can take you from the baseline to that final distribution, which DCEA aims to incorporate into the analysis. And so we want to be able to incorporate the distribution of benefits, and there's a range of factors that influence this. So that can involve the distribution of the eligibility for your intervention, the distribution of uptake, and the distribution of effects. DCEA also attempts to apply the distribution of health opportunity costs. This accounts for the idea that the funding used for this intervention would have been used for something else, and the effects of that something else could be unevenly distributed across the population. So the distribution of those health opportunity costs are also meant to be incorporated into your DCEA to get to that final distribution. So once you get that final distribution, DCEA can stop at this point, and you can informally, assess that distribution to work out whether you should fund a particular health intervention or not. However, if that decision isn't completely obvious yet, then there's further analyses you can do to support decision making. The first option is to use dominance tests, which assess those final distributions under each of your scenarios to work out what is the more favorable distribution under some defined efficiency and equity principles. I'm not going to go into those tests in that much detail. They're not used as often as some of the other analyses. Then we have the calculation of inequality indices, and there's many different indices that you could use here, and some of these might be more relevant for your context than others. And this allows you to consider the trade-offs between cost effectiveness and equity. And if there is a trade-off, then you can apply equity weights to help work out whether that trade-off would be considered worth it or not. And then there's two different types of equity weights. There's direct equity weights, which involve applying weights to health outcomes to specific social groups. For example, the lowest socioeconomic group, to then increase the value of the outcome in those groups. Then we have indirect equity weights, which is focused on applying a weight to health outcomes and gives greater priority to those who have poorer health. Both of these weighting options require quantification of the social value of reducing inequalities, which, as we know, is a normative measure. So that's sort of a summary of the different components of the DCEA, and now I'll run through an example from the UK. This was one of the first DCEAs published about a decade ago now, and was presented as a case study to demonstrate the methods. So the topic was bowel cancer screening. They had 4 different scenarios. The second of these was screening as it had already been introduced, and then they also had a no screening scenario. What they knew about that standard screening scenario is that there was greater uptake in sort of the less deprived or higher socioeconomic areas in the UK, which meant that it was actually widening inequities. Then they had two scenarios with that added reminders for the screening program. And so one of these reminders was targeted to the more deprived and ethnically diverse areas in the UK, and the second one was a universal reminder for the whole population. And so they were comparing these 2 scenarios with the standard screening, this analysis. And this is just to point out that the standard screening scenario compared to no screening scenario would have sat in this win-lose quadrant of the health equity impact plane, where it was more cost effective, but it did harm equity. So in this analysis, we're comparing the reminder scenarios with the standard screening scenarios. So they started with simulating distributions at baseline, and so this is their baseline distribution of health. You can see that there's an increasing gradient in quality adjusted life years. And then they applied the different distributions of uptake. And so you can see with the standard screening approach, there was quite a steep gradient of uptake of screening. In I don't know if you can see this, in this universal approach, there's also still a steep gradient there, but overall it did increase uptake. And then in our targeted approach in the solid line there, for all of these quintiles, it did increase uptake, but it overall flattened the gradient of that uptake. And so incorporating both the baseline distribution and distribution of uptake, they were able to get to their final distribution of health across our 3 scenarios. So in itself, it wasn't obvious from these distributions which was the more appropriate scenario, and so they did go on to evaluate these distributions, and they chose 3 different components of that section. So they did conduct some dominance tests, which allowed them to partially order their scenarios, and then they calculated inequality indices. I'm not going to present each of these indices, but they actually calculated 6 different indices in their analyses. And all of these indices presented sort of a similar direction to the results. And then the final step, they did apply indirect equity weights. So just to show you those results, they didn't actually present an equity impact plane in the paper, but based on those inequality measures that they did calculate, it demonstrated that compared to the standard screening approach, the targeted screening approach increased health equity and increased cost effectiveness. But the universal approach also increased cost effectiveness, and more so than the targeted approach, but it did harm equity. And then, so that demonstrates that, the targeted approach was more favorable than standard, and the universal approach would have required a trade-off between equity and cost effectiveness compared to standard. But if we were to choose between the universal and targeted approaches, then now we have a trade-off overall between cost effectiveness and equity impact, because the targeted approach was less cost effective than the universal. So to support that decision around universal and targeted approaches, they went on to apply indirect equity weights. So this graph, if you haven't seen one of these before, is a bit complicated, so I'll try and run through it. So this y-axis here is demonstrating the overall, or the difference in the overall social value of the universal reminder system versus the targeted reminder system. And that overall social value is quantified by this measure called the equally distributed equivalent of health. And this is accounting for the overall cost effectiveness, the equity impact, and the level of concern a population might have for equity versus cost effectiveness. So it's a measure of how willing society is to trade off cost effectiveness with equity. And then the x-axis here is what that measure of inequality aversion is. So this is essentially a sensitivity analysis saying that at each of these different levels of inequality aversion, which of these two reminder systems would give society an overall higher social value. And so when the line's above the x-axis, this is saying that we should choose the universal approach. And if it's below, it's choosing the targeted approach. And I should have had these come up earlier, but the more to the left, the line is that's about that tells us society doesn't care about equity, and the higher that Atkinson number is, the more society cares about equity. So overall, this graph is showing us at lower levels of inequality aversion, the universal targeted approach gives us greater social value, and at greater values of inequality aversion, it's saying that the targeted approach is the way to go. So that's sort of a summary of that particular paper, and does go through a lot of the steps of a DCEA. This is my example from my PhD, in which I used that childhood obesity model to conduct a DCEA for 3 different obesity prevention and treatment interventions compared to a no intervention scenario. I'm not going to go through every step of what I did here, but essentially in this analysis, I accounted for differences in baseline health, in eligibility, and in effectiveness of each of the interventions. I then calculated the slope index of inequality, which is another measure of equity impact, and that's what I plotted on the x-axis here. And the y-axis here is cost effectiveness, or another way of presenting cost effectiveness is the net health benefit. And so that x-axis here is representing our threshold for cost effectiveness. So with this analysis, 2 of the interventions ended up in that win-win quadrant, and 1 of the interventions ended up in the lose-lose quadrant. And you can see from the graph that there is an ordering there. There's no trade-offs required between cost effectiveness and equity impact in each of our scenarios. And it's clear that that red intervention was the more favourable one in terms of both cost effectiveness and equity impact. So because it was obvious at this step, I didn't need to go on and apply equity weights to support further decision making. So this study was a demonstration of DCEA, but it did require several assumptions and the application of some uncertain parameters. And so I did a range of sensitivity analysis around this as well. But that's just an overview of that study. So that brings us to this question of whether we can use DCEA in Australia yet. One of the things that is commonly presented in DCEA presentations are these 5 building blocks that are required to get DCEA ready for a new country. So I've done a lot of thinking around, where we're at with those building blocks and where we're likely to get. So I thought I'd just run through sort of my thoughts on this. So the first of these is the consensus on a social distribution, social disadvantage classification system. So this is saying, we need one set of variables. It can be a combination of a couple, but still one system in which we classify the population to conduct all DCEA studies with. So in Australia, we definitely don't have consensus around that, but there's many priority populations that have been identified that in health policy and in general community. And I've got some examples there. So I'll discuss this a little bit further, but I do feel like this one's going to be one of the more challenging ones to get solid in Australia. Then we have the social distribution of baseline health. And so this is supposed to be based on the disadvantage classification system from the first building block. And as of this year, we have 2 studies, and I think Sheridan, who's the first author of these papers, presented one of these studies in the last SIG webinar. So this is giving us our first estimates for quality adjusted life expectancy by 4 different variables. So that's a huge step forward in being able to conduct these studies. Then the next one is having a quantification of the social distribution of opportunity costs. And we don't have that for Australia yet. There is one published example from the UK, which shows an uneven distribution of these opportunity costs. Although recently there's been a lot more commentary about this potentially actually being more even. So there's uncertainty around that even in the UK, and we don't have any estimates for Australia yet. So to be able to apply that part of the DCEA, we have to make assumptions about this. And that's exactly what I did with my analysis. I started with a flat distribution as a primary study, and then used the UK distribution as a secondary analysis. I do think this is probably one of the stronger assumptions that we do have to make, though, at the moment. And then there's getting a plausible range of equity weights. So again, as of this year, we have our first estimates of this across 3 different social variables. And these have been published, so that's really exciting. It's something we can now apply. In general, there's a bit of controversy around applying equity weights, within DCEA, but also outside of DCEA. So that's just something to keep in mind. And again, I'll discuss that in the next slide. And then finally, consensus around a headline equity metric. Again, I think this is going to be a little bit challenging to get consensus. It's, again, dependent on our social disadvantage system. And in Australia, yeah, we don't have that consensus. I presented the SOAP index of inequality in my study, but there's lots of other options. Something to keep in mind potentially there is that some of these metrics can be quite complex to interpret, and some of those incorporate equity weights directly and some of them don't. So there's a bit of variability there, and I think we need to think about the policymaker interpretability and acceptance of those. Okay, so I guess in answer to that question, can we use DCEA in Australia yet? I'd say we can, but we need to make, because these building blocks are not solid yet, we need to make some assumptions, and we need to make some executive decisions on things that we don't have consensus on. So I've hinted at a lot of this now, but I wanted to present some of my perspectives on how we can apply DCEA in Australia. So I personally think we need some flexibility around these building blocks, particularly that first one around having one social categorization system to do all DCEAs. The reason for having that as a building block, and having any of these building blocks really, is to allow us to compare the results of different DCEA studies well with each other, and that's a fair and important reason for that. However, I do think there's some risks around that as well. You know, different interventions, different programs will address inequities in lots of different ways and for different groups. And by choosing one categorization system compared to another, we might actually be having some unintended consequences of disadvantaging some groups versus others. So that's my thoughts on that one. Also, when it comes to headline equity metrics, I would reconsider using measures that directly incorporate equity weights as our headline metric. I still think it's really useful as a second step, like was conducted for that first study I mentioned. But as our primary measure of equity impact, I think there's some questions around that. So particularly with the equally distributed equivalent of health, because it's a measure of overall social value, accounting for both the cost effectiveness and equity impact, if you have an intervention that's really effective or really cost effective, then it could actually obscure any impact on equity. So if it was really cost effective in high income groups, for example, you could still have an overall very high equally distributed equivalent of health. So it potentially is not the best measure of overall equity impact. And then we have the measures, there's a broader set of measures that incorporate equity weights, and in general, the application of these weights at a policy sense is a little bit controversial, and they're also likely to fluctuate with different social as social circumstances change, as political circumstances change. And so I think the best way to use these weights and the EDH in particular is as they used in that first study I discussed, where it's used as a sensitivity analysis on the overall value of a program. And then the last point is something I haven't mentioned yet, but I've highlighted that to be able to plot your DCEA results onto that equity impact plane, we need to decide on a threshold for cost effectiveness to say whether something has a net health benefit or not. And we don't have that threshold in Australia for very good reasons, but it does create a technical challenge for conducting a DCEA. So the way I dealt with this with my study was to apply a $50,000 per QALY gain threshold as a primary analysis, and then conducted sensitivity analysis at $28,000 using a recent paper, actually not so recent anymore, but a paper from Edney et al. So there's lots of options there. I think the best way you can manage this is to be really transparent about what you've used and to conduct sensitivity analysis around it. I then just wanted to go through my thoughts on using DCEA as part of a trial analysis. And I guess the main point here is that DCEAs are inherently a modeled exercise because we're talking about assessing the impact on health inequities across a full population, and you're never doing your trial on the full population. So what can be done with trials, though, is to identify relevant data that can be incorporated into your modeled analysis. And so the main things that I think we can get from a trial would be data on differences in effects across different social groups, provided that the trial is set up to power such an analysis. And then we could also get some information around uptake, again, if we are measuring the right things. So if there's some measurement in place around recruitment and who's accepting or not accepting invitations to be part of a trial, that could give us some information about uptake. And also measuring adherence and the characteristics of those who remain within the trial and not. We would then need to incorporate that with external data and probably assumptions, as I've already mentioned. So as with any cost effectiveness analysis, that would mean that sensitivity analysis is quite important. And again, this is not a unique point to DCEAs, but I think it's quite important to consider the decision maker for the particular intervention or program that you're trialing. If it's federal government, then you want to be doing your DCEA for the full Australian population. If your decision maker is state government or a hospital setting, then you probably want to do your DCEA at that smaller scale so that it's relevant to the decision maker. So I also wanted to go through some alternative options for equity informative evaluations. As I said earlier, my fellowship is looking at the range of different types of methods available and what might be applicable in our context or in specific, or whether it needs to be tailored to specific types of I guess, policy questions. So with DCEA, generally they are focused on inequalities and inequities in health outcomes. But there's lots of other ways in which equity can be considered. So we've also got extended cost effectiveness analysis, which considers the distribution of health and non-health outcomes, and often focuses on financial considerations and the distribution of out-of-pocket costs in particular. So this one, although it's often conducted in low to middle income countries, I do think there's some value in these analyses in high income countries as well, particularly around that consideration of out-of-pocket costs. There's multi-criteria decision analysis, which isn't sort of focusing on one type of equity in particular, but it can be a criteria considered alongside other decision-making criteria, and it can be used with or without an algorithm to support decision-making. Then we have equity weighting, which applies, so I've discussed weights already, but they apply a weight to the level of concern for health in particular groups. So this can be used within DCEA, or it can be used separately. So you could just directly apply an equity weight to an incremental cost effectiveness ratio, or even a threshold to apply these weights. And then finally, so these first four analyses are presented in a systematic review by Ward et al., and I've got the references at the end for those of you who are interested. This last one it's not exactly, it is, to me, it is an equity informative option. So this is just conducting an economic evaluation that incorporates non-health outcomes, and this is as opposed to extended cost effectiveness analysis, which is looking at distributions, whereas a CBA or just a separate analysis might look at this data as in aggregate. And by incorporating non-health outcomes such as access to disability support services, education outcomes, impacts on the criminal justice system, this might be considered a more equitable way of looking at the overall value of an intervention, particularly things in prevention or in community health, where they can have that broader value. So that in itself is often argued as an equitable approach to economic evaluation. So almost done. So in conclusion, DCEA is a promising and exciting methodology. It's gained a lot of traction globally, and it could be used to promote fairer resource allocation decisions. However, I think that we need a bit of flexibility around building blocks to apply DCEA in an Australian policy space, and there's still some key quantifiable data inputs that need to be derived to be able to use it with less assumptions than we have to use it at the moment. And then the final thing is that other methods might be more appropriate for your specific health resource allocation decision. So I think it's important to think about, what you're actually trying to get out of your analysis, and then deciding your method based on that. In terms of upcoming work from me, I'm currently got a paper with some co-authors at the Leader Centre, which is a commentary around application of equity informative methods in Australian HTA. That's under review, and I'm hoping that will be out sometime soon. I'm also at the data collection stage of some qualitative work with Australian health policy makers on the current use of equity evidence in decision making and preferences for future developments. And then just having gone to a few different conferences this year, it's very obvious that there's lots of different DCEAs going on, particularly in our Australian context. And I think there's probably a few people in the audience today that are doing it. And so I suspect there's going to be some DCEAs for Australia published in the next year or so. So look out for that. That's everything. These are my references, the key ones that I mentioned today. I'm very happy to take questions now. Thank you, everyone.
That was wonderful. Thanks so much, Annika. If people have any questions, if you could just raise your hand, that would be fantastic. There was an amazing amount covered in that, Annika. Can I just ask, are there any, healthcare decision makers around the world already incorporating DCEAs into, for example, HDA assessments and that type of thing? Like, would they be, obviously I don't know what would happen if someone presented, a DCEA at PBAC or MSAC.
Yeah.
But are there different policy makers around the world who are, already accepting DCEAs in decisions?
So I think as of this year, and there might be others in the audience that can give more context around this, but in the UK, NICE now have it as an option to conduct a DCEA, and I think they've called it in their guidance a modular product. That's probably the extent I can tell you about, but yeah, whether it's actually been presented in that HDA context, I'm not sure, but it's allowable and they're promoting it.
Yeah, fantastic. Manuel?
Hello, hi everyone. Thank you very much. A great presentation. This is a very practical question about the methodology, really. When you build your cost equity plane, or efficiency equity plane, which metric do you use to represent the reductions in inequalities or equity improvement? Some people, use Gini coefficients or gaps or whatever, and so there are different measurements. And actually, my perception is there is no clear consensus how to present that, and that sometimes it's not very clear. And you're comparing, apples and pears, and it's not really the same thing, right?
Yeah, completely agree. And I don't think I did make it obvious in that first paper. My paper, I presented it as the slope index of inequality. So it's an absolute measure of difference in health between socioeconomic groups, for my example. And it's a measure that doesn't directly incorporate an equity weight into it. So it's more of a measure of inequality than equity, and the equity part you kind of have to assume based on the grouping that you're using. So the fact that I'm looking at socioeconomic groups and then that we're seeing a difference between groups, I'm calling that inequality and inequity. In that first study that I talked about from the UK, they actually just reported 6 or 7, I think it was 6 different equity indices. So they had slope and relative index of inequality, but they also had presented the Gini coefficient or Gini index, Atkinson index, EDH. So they presented everything. And from memory, they were qualitatively consistent with each other, but that doesn't mean that they're always going to be. So I don't know if I'm answering your question, but yes, I agree that the fact that we've got all these different ones, we definitely don't have consensus in Australia around which one to use. If we want to compare one DCA with another, then that will be another challenge. I think the other point there is that they're somewhat dependent on the grouping that you use, the social categorization system that you use. So if you have something that's binary or what's the one where it's categorical but there's no ordering to it, then that's going to make it difficult to use a lot of these metrics. You'd have to use something a lot simpler.
Thank you.
And again, there's just a question or a comment in the chat. I don't know if you have access to the chat or if you want me to read it out.
Opening it up now. So could it be argued that DCEA generally favours targeted as opposed to universal programs, as the latter involves rich people also getting access to programs? However, it doesn't that overlook a key aspect of equity universalism. Yeah, so that's a good point. I think it depends on how what you're incorporating into that targeted versus universal approach. It's possible that a universal approach is actually more likely to catch the right people because it's being provided to everyone, if that makes sense. So an example from the newborn screening focus that I'm looking at is that a targeted approach for screening for sickle cell disease, for example, would require you to target particular ethnic groups, and whether that targeting happens, fully and catches all the right people is unlikely. So there's reasons why we're not going to catch all the right people with that targeted approach. But with a universal approach, because it's being provided to everyone, then everyone gets caught in that. So I'd say it's not always going to favor the universal. Sorry, it's not always going to favor the targeted versus universal. But I also get your point that it's not that overlooks another aspect of equity, and I think that's an issue for DCEA and for these methods in general. It's equity as a term has a broad and many dimensions of meaning, and people think about it in lots of different ways, and there's lots of different principles around it. So with DCEA, we would need to be really clear about how we're defining equity when we're presenting, and we are only ever looking at one aspect or one dimension of equity when we're doing those analyses. I hope that answers your question.
Are there any other questions from anyone else? Please just raise your hand or pop it in the chat. And if not, Annika, thank you so much. That was an amazing presentation, and obviously lots for us to think about and lots more work to do. Natalie did just have up the QR code to do the post-webinar survey, but Natalie, I believe that will also be sent to people perhaps, but we really do appreciate people's feedback. Sorry, Natalie?
Yes, it will be sent to people with the recording.
Also, yeah, thank you. So everyone will receive an email with a link to the recording and the survey. We really appreciate people filling out the survey, and in particular letting us know about any topics that you or one of your colleagues think would be of interest to this group to present at our webinars next year, or something you'd be interested in hearing and you perhaps know of someone internationally who might be able to present that. So please do let us know, because we obviously want the webinars to be of interest to what people in this group are hoping to learn about. Just a reminder that the ACTA Clinical Trials and Registry Symposium is not next week, but the week after in Melbourne at Crown Promenade. There's also a workshop related to health economics, so costing implementation strategies and enhancing economic evaluations in trials. Some of you will have seen Thomasina present a webinar to this group on the cost IS instrument before, but that workshop still has availability if anyone is interested, and you can still also register for the symposium, which has a great program. So we will be in touch with regarding our next meeting, which is likely to be during the symposium, but we will confirm that to you all when our next whole SIG meeting is. And in the meantime, if you have any queries, please just email us either by Natalie or emailing Nung and myself. And we look forward to hopefully seeing everyone in the next few weeks at our next meeting. But Annika, a huge thank you to you for your presentation today.
Thank you so much for the opportunity to speak.
Thank you all. See you all soon.